Good evening. My name is Sarah Coffey. I'm one of the nurse practitioners that comprises the structural heart team at the Mayo Clinic here in Rochester, Minnesota. I'd like to take this opportunity to thank the Minnesota ACC for this opportunity tonight to share as part of a CV Team member. I have no disclosures this evening. Objectives. So a short period of time to talk about a huge subject, but let's talk tonight about the benefits and challenges of developing a robust structural heart program, defining who that multidisciplinary team is, and then discussing the role of the advanced practice providers as members of that heart team. So benefits, let's start with that of a robust structural heart team. So we have options for patients for procedures that 10 years ago would have had no options because of high surgical risk. Now we have percutaneous options that are less invasive, have faster recovery, and a return to quality of life. With these procedures, patients have the opportunity to help personalize and individualize their treatment plans. With structural heart programs, we have access to clinical trials that would not have been available otherwise. We provide emphasis on involving, again, the patient in their plan of care via shared decision making. The challenges in developing and sustaining a successful program. This is a busy slide, but I'll pick a couple of the big challenges that we have faced here at the Mayo Clinic and go through those. I think one of the big ones at all institutions that's a barrier or a challenge is the financial constraints that come with the structural heart program, and how do we optimize reimbursement. So a couple of years ago, we were asked as a structural heart team to look to see how we could make the structural procedures more cost effective while preserving superior clinical outcomes and protecting our patients. So we started looking at where we were doing our procedures at. We looked at both OR procedures and cath lab procedures. We identified that there were patients that were being done in the OR, the operating room, that didn't necessarily need to be done in the operating room. They could be done in the cath lab. When we looked at the financials of that, we realized that we could do 3 structural patients in the cath lab for the price of doing 1 in the OR. So we made a paradigm shift and do most of our cases now in the cath lab, which was a huge area to help optimize reimbursement. We did general anesthesia for a while in the past, and have switched to conscious sedation for most patients, which has proved to help optimize reimbursement and save money for the institution. Then we also do nurse-led sedation now, which is something new over the last couple of years that also has saved in the financial area. One of the other challenges I hear a lot at other institutions that are new programs, how do you build that referral base? I always ask myself when I'm with this, what matters most to the referring provider? Ease of access. So do they have a contact that they can call to review their patient to get them in? Can we do it in a timely fashion? Are we communicating with them as to the plan moving forward? Good clinical outcomes are obviously important to them, and then transfer of care back to that referring provider after intervention. So those are things that we have found when we do that. The referrals come, we get many more referrals. Other ones that are hard, evolving clinical care pathways. That's one of those on here. Constantly evolving with COVID. We were look at bedding, and we're able to actually start participating in doing some safe same-day structural discharges safely. Again, we talked about the type of sedation, and then location of recovery. We used to have our structural patients go to a physician led service, and recently, within the last 6 months, have transitioned to a NPPA run service post procedure, which now our structural patients go to. Structural heart planning. So we're going to talk about the complexity of this, and then who makes up the team that helps make these decisions. So again, pre-procedural shared decision making. So who is a good candidate for these procedures? Who is their support structure? We start talking about early discharge planning right off the bat. Who do we identify that are going to have obstacles post-procedure that may not be able to be discharged to home? Working with the patients to manage expectations, and we'll talk a little bit more about that. Technical planning for procedures, so we're using the information that we've obtained to make sure that they are good candidates, they have good anatomical landmarks for procedures. Always emphasize patient safety, heart failure teaching, registry data collection, and then follow up for sure. It takes a village. A structural heart team is a village. In looking to do this presentation, when I looked at the heart team, most of the models comprised interventional cardiologist, a cardiothoracic surgeon, the cath lab staff, anesthesia, the referring cardiologist, echo physician, and a coordinator, which may or may not be an NP. But there was a key person missing in all of these that I saw, and that is the advanced practice providers. I think advanced practice providers play a key role in structural cardiology. Oftentimes we're regarded as the faces of the program, and the local experts for questions or concerns. A lot of times we are the first go-to for referring providers, referring within house. We're accessible. Providers often come to us. It's good continuity of care for patients. Again, in our institution, on the front line, NPs and PAs are talking to referring providers or self-referred patients, getting the information needed, reviewing imaging records, making sure they have adequate workup, making sure what has not been done is completed upon arrival, and then we see the patients prior to discuss options and are part of that multidisciplinary heart team. Here in our cath lab and our OR, NPs and PAs are not in the actual procedures. We have fellows, but post-procedure, as I said, patients go to this NP-PA-led service, and then upon discharge, they are set up to follow with structural heart NPs. Often the liaison between the physicians and the nursing staff, continued source of information and education for patients, for families, for staff. This is something that's very important as we continue to do research studies and new procedures, that we're making sure that we're educating our staff as to the procedures, the complications, what to look for. So making sure everybody on the front line taking care of these patients are prepared and adequately educated. With that and the constantly changing data and trials, we need to make sure we're up to date with our current literature and research options, and then looking at our information and making adjustment to clinical pathways as needed. Quality initiatives are often driven by the NPs or PAs, whether it be bedside quality initiatives, clinical documentation improvements, looking at decreasing length of stay, continuing patient education, or working with referring providers. This is usually quality that are initiated by the NPs, PAs. anytime we're looking at making a robust program, I always say, let's look at what we've learned in the past over the last decade, and then look to where we're headed. We have a shift in focus. I feel like not just can we do these procedures, but should we? Who are the ideal candidates? And looking at the data and the literature, over the last decade, we can see who benefits the most from these procedures and who doesn't benefit. We're going to talk about a few questions asked involving the patient. What does the patient really want? And the heart team, which includes you, the NP or PA, or anybody on the CV team, is instrumental in this process of patient selection. Patient selection. So this is something I always try when I'm seeing my patients to try to get from them what their goals and expectations are with these procedures. I often use, in your own words, tell me about your quality of life. If you had to live every day of the rest of your life like you are today, how happy would you be? I ask them, what do you currently want to do that you're not able to do? And then if they give you certain tasks, what limits you from doing that? Is it their shortness of breath or chest pain, or is it the fact that they've got joint pain or knee pain? Defining what's really important to them, asking them, acknowledging that this is a lot of information, can be overwhelming, asking them what confuses them most about the treatment's options, what are their most feared outcomes, and then addressing them. All things that are really beneficial in providing patient-centric care and making sure they are part of that team as well. So again, multidisciplinary team approach to finding the best care for the patients. We include the patients in those decisions. Again, short 10-minute overview of some of the benefits, challenges, and team members that comprise the structural heart team. If you are thinking about going into structural cardiology or starting a structural cardiology team, have any questions, you could email me. I would be happy to help. Again, I want to thank the Minnesota ACC for this opportunity. Have a good evening.